Christine Kennedy, and I work in the Office of Alumni Engagement. And on behalf of myself and the McMaster Optimal Aging Portal, I'd like to thank you for joining us this evening as we hear from Doctors Jason Busse and James McKillop, researchers with the Michael G. DeGroote Centre for Medicinal Cannabis Research. Dr. Anthony Levinson is here again to moderate this evening's festivities. Those of you who are unfamiliar, Dr. Levinson is a professor at McMaster University and is a neuropsychiatrist practicing medical psychiatry in Hamilton here. He is the director of the Division of E-Learning Innovation in the Faculty of Health Sciences and is a part of the leadership team for the McMaster Optimal Aging Portal. We're so excited. We had a tremendous registration number. So thank you everyone for joining us. Anthony, I'll let you take it away.
Thank you so much, Christine, and welcome everybody to tonight's webinar. We're really pleased to have Dr. Jason Busse, Dr. James McKillop. So I'll just briefly introduce Dr. Jason Busse is the Associate Director of the Michael G. DeGroote Centre for Medicinal Cannabis Research and is a professor in the departments of Anesthesia, as well as Health Research Methods, Evidence, and Impact here at McMaster. And Jason's research interests include chronic pain as well as evidence-based practice. Dr. James McKillop is the director of the DeGroote Centre for Medicinal Cannabis Research and the director of the Peter Boris Center for Addictions Research. He's a professor in our Department of Psychiatry and Behavioral Neurosciences, and his research interests include the nature and treatment of substance use disorders and related conditions. So we're really pleased to have both of these guests here tonight to talk about cannabis and its role in common conditions. So a few housekeeping points. There will be a recording of this webinar, and it will be made available through both the Alumni Association website as well as through our McMaster Optimal Aging portal as a video post. And then the questions that were sent in advance, we are going to try to address those during the webinar. So there's no need to resubmit a question that was submitted in advance. And then if you have other questions, please put them in the Q&A pod. And we are going to do our best to get through everything and wrap up by 8 p.m. tonight. So without further ado, Jason and James, welcome.
Great to be with you.
Yep. Thanks so much for the invitation.
All right. Well, why don't we're going to start off with, you're going to walk us through a little bit of background about the center and some of the work that you are both doing in the area of cannabis. And then we'll move to sort of Q&A related to a wide range of different topics that were sent in advance, including the use of cannabis for conditions like chronic pain and arthritis and other neurologic and psychiatric conditions. So take it away.
Sounds great. Great to be with you tonight. My goal in these first few slides is just to sort of give you an overview of what the DeGroote Centre does, our perspective on cannabis, and kind of the big picture 10,000-foot perspective on the evidence base of cannabis for various conditions. So let me start by telling you a bit about the DeGroote Centre. And this was a center that was created at McMaster in 2017 in recognition that many more Canadians were using medical cannabis than ever before. And that was not because there was a sea change in the amount of evidence that was available. It was more to do with the fact that it was much more accessible. And there was a real need for evidence-based perspectives on whether cannabis actually was effective for many of the conditions that it was being used for. And that's really the heart of our center's vision, to provide an evidence-based understanding of medicinal cannabis, including both its therapeutic effects and its associated risks. The idea is we're not pro-cannabis, we're not anti-cannabis, we're pro-evidence. And in some ways, we're an umpire. We're called balls and strikes when it comes to the state of the evidence, and try to promote best available evidence in terms of helping people make good decisions. In terms of our mission, the mission is to use the highest standards of research methodology to advance the understanding of cannabis. And there were really three prongs to what we try to do. The first is to curate the collective body of knowledge on medical cannabis. And what this really means is understanding what the state of the evidence is. This is often in systematic reviews or meta-analyses or critical reviews of what we really know about the benefits and harms. The second part of the mission is to create a network of cannabis scientists and clinicians at McMaster and its affiliated hospitals to really create a network of individuals who will advance the science in this area. And being a research center, of course, at the heart of our center is conducting innovative research to try to advance scientific discovery and produce the next generation of evidence when it comes to medical cannabis. What this looks like in terms of some of the resources that are available, in terms of our mission of curating the evidence base, for anyone who's interested in more information after this talk tonight, I would very much encourage you to come to our website, cannabisresearch.mcmaster.ca. You'll find research summaries and evidence briefs, which are essentially knowledge translation products that make sense of the emerging findings from the scientific literature. We also put on a free annual conference called Innovations in the Science of Cannabis, and we encourage people to participate. We invite scholars from around North America to present on their work, as well as local trainees and researchers at McMaster. And then the other piece of our priority for curating the evidence base is that we've created a 3-course certificate in professional learning in the science of cannabis. And this is in collaboration with the Center for Continuing Education at McMaster. So if you really want to do a deep dive into what is cannabis, what are the risks, what are the benefits, this certificate is a way to do that and earn a certificate of professional learning. In terms of our research program, in some ways it's fitting that we think of it as being a yin and yang of cannabis. We're really interested in understanding what are the benefits, what are the conditions for which there is evidence that cannabis may be helpful, and equally, what are the potential harms. We want to understand the balance of potential benefits to known risks and provide the kind of evidence that patients can use to make good decisions in their healthcare. And what this looks like, practically speaking, falls into a number of different conditions that we are prioritizing. So on the therapeutic benefit side, our research center is heavily prioritizing understanding cannabis for pain, including both cancer-related pain and non-cancer pain. We're very interested in cannabis as a candidate treatment for sleep disorders, possibly for anxiety disorders. Interestingly, there are faculty affiliated with the center who are looking at different cannabinoids in topical uses for reducing antimicrobial resistance. And we're also interested in applications of cannabinoids for substance use disorder, especially alcohol use disorder. When it comes to some of the potential harms, we're very interested in the risk of developing cannabis use disorder in general and among individuals using medical cannabis. Unfortunately, we know from the opioid epidemic that it is not impossible for people who start using a psychoactive drug for a medicinal purpose to ultimately develop an addiction to that drug. So we're very interested in understanding the abuse liability and the phenomenon of cannabis use disorder in general. We're interested in how cannabis affects cognition, memory, learning, performance, as well as whether it can potentially exacerbate some psychiatric disorders. And then because cannabis is still typically consumed via inhaling smoke, we're interested in whether or not it substantially contributes to lung harms. And finally, we're very interested in some of the novel harms that seem to be emerging with the increasing levels of THC in cannabis, especially phenomena like cannabis hyperemesis syndrome, which is a gastrointestinal syndrome involving nausea, vomiting, a great deal of distress, and this seems to be brought on by cannabis. The last piece of the puzzle for our center is really focusing on understanding the impact of legalization. Our center started in 2017, the year before legalization took effect, and it would be impossible not to think that legalization of recreational cannabis wouldn't also affect medical cannabis and cannabis use in general in Canada. So that's the third prong of our research profile. We also know that the benefits and risks of cannabis do not fall equally across the population. So we've prioritized certain subpopulations where we're particularly interested in understanding benefits and risks. This includes adolescents and emerging adults, Indigenous individuals, individuals with psychiatric disorders, Canadian veterans, and also seniors. And given that this is a presentation in the Optimal Aging portal, I thought I'd dive a little deeper into why we are prioritizing seniors. So in terms of the overall population, although seniors use cannabis at the lowest absolute rate, the rate of increase is actually highest among seniors and has been for a number of years. Many seniors are either trying cannabis or returning to cannabis, having used it earlier in their life, and are very curious about whether or not it might be of interest for recreational or medical purposes. Many seniors, unfortunately, do struggle with chronic medical conditions and are interested in medical cannabis as a novel therapeutic strategy or a strategy to reduce their reliance on other medications and perhaps reduce side effects. We know that people endorse cannabis as being potentially useful because they perceive it to be natural and less harmful than pharmaceutical drugs. Of course, there are lots of natural products that are also harmful too. Most mushrooms are harmful, but the reality is many seniors do report cannabis being appealing because of its natural status. Many seniors report getting advice from family members to consider cannabis for chronic health conditions. And we also think that there's a certain profile of potential risks that we need to be aware of in seniors. So we know that as a psychoactive drug, cannabis can lead to increased risk of falls or other motor impairment. It can exacerbate cognitive difficulties, perhaps accelerating or masking cognitive impairment. And the other reality is that cannabis and its constituents are biologically active molecules. And as a result, they can interact with other drugs. And because unfortunately seniors are often taking multiple drugs, the risk for interactions is necessarily higher. So seniors are really a high priority subpopulation for our center. Just to give you the big picture in terms of what we know about the evidence base when it comes to medical cannabis, it really is not a black and white issue. It's not a matter of cannabis works for everything or cannabis works for nothing. What we know is that for some conditions, it can be quite effective. So one example are these findings from a clinical trial published in the New England Journal of Medicine. And this is looking at purified CBD for seizure disorders, a seizure disorder in children. And in this case, what you can see is that this CBD formulation at a high dose basically reduced the frequency of seizures by about 23% overall, a significant effect. And this is one of the studies that led to cannabidiol or Epidiolex being approved by the FDA as a medication for treating pediatric seizure disorders. Our center, in this case led by Jason Busse, has also done a recent rapid recommendation on cancer for chronic pain. This was specifically focusing on cancer and non-cancer pain, including neuropathic pain, nociceptive pain, and nocioplastic pain. And just to summarize the findings quite briefly, what it found was that there was moderate evidence favoring cannabis for a reduction in pain, an improvement in physical function, and an improvement in sleep quality. Not a large effect necessarily, and with some evidence of side effects, but enough for this review to conclude that a weak positive recommendation was warranted. What about for psychiatric conditions? That's a common question, and many people say they're using cannabis for psychiatric conditions. One of our faculty affiliates recently did a review of this literature and unfortunately found that the evidence was almost wholly lacking when it came to using medical cannabis for psychiatric conditions. And that actually concurs with what we've recently seen from the Canadian Psychiatric Association, which put out a position statement strongly advising mental health professionals to be very cautious when it came to using cannabis for treating mental health conditions, especially if it meant delaying evidence-based strategies or replacing evidence-based strategies for treating mental conditions. What about sleep disorders? We also often hear about sleep disorders, and our center has actually done 2 reviews on the topic, first in 2019 and then a more recent one in 2022. And what we see is actually much more promising. Here we see that although it is primarily studied as a secondary outcome, not the primary focus of the trials, there is evidence that cannabis seems to be associated with increases in sleep quality, decreases in sleep disturbance, a decrease in sleep onset latency, which means how long it takes to fall asleep. And there are questions about these findings. Are they direct effects of cannabis, or Is the product reducing pain, for example, and as a result, improving sleep? And most of these findings are not using objective measures, but on balance, the literature is generally quite favorable. And in the most recent systematic review and meta-analysis, it was found that there was a significant small benefit for individuals with non-cancer pain, albeit with increases in dizziness and increases in dry mouth, fatigue, and nausea. So it's not as simple as it works or it doesn't work. It's a mixture of potential benefits and potential harms. So just to conclude, what we see from the 10,000 foot perspective is really not a yes/no answer to the question of does cannabis work for medical purposes. It's a spectrum of outcomes. There are some cases where there's quite strong evidence, as in the case of pediatric seizure disorders. There are other conditions like pain and sleep where there is moderate or at least limited but suggestive evidence. There's quite promising evidence for some substance use disorders, although it's early stage and from individual trials. And then there are areas where it doesn't seem like there's very convincing evidence at all. There are some observational findings, but the randomized controlled trials don't show clear evidence of benefit. So it really is very much a spectrum on a condition by condition basis. So last point to make is that with all of these benefits, one has to be aware of the risks of cannabis. And we can divide these into the acute risks that people experience when they consume the product, and also the chronic risks that come from using it heavily or frequently over time. These acute risks include performance impairment or motor impairment. There are associations with car accidents, for example. Although you can't overdose on cannabis to the point of toxicity or death, you can overconsume, and cannabinoid-induced delirium or psychosis are real phenomena, and overconsumption can certainly lead to some very negative outcomes. And then acutely, there are other adverse effects on cognition, especially when it comes to attention, learning, and memory. When it comes to chronic risks, as alluded to before, cannabis use disorder is a real phenomenon. For a long time, people thought that cannabis was not addictive. We know that that's not the case at this point. There is an increased risk of psychotic disorders, especially among people who have a family history. We know that there are chronic adverse effects on cognition, again, primarily in terms of memory and learning. And we also know that there's an association between persistent cannabis use and self-harm and suicidality. Last, there are lung harms and also cannabinoid hyperemesis syndrome, which are medical complications of long-term, typically heavy cannabis use. So with that, I'm going to stop there. That's our 10,000 foot perspective on our center. I look forward to now hopefully answering some of your questions.
Can I just chime in a little bit? I guess a few things that, one, I want to say that some of the questions do get more personal, and I just want to reiterate that we are not able to provide medical advice, so we will try to take or translate any very specific questions into sort of educational talking points. So at this point, though, I also wanted to throw out a few polling questions. And so Shelley, could you put up, we have 3 polling questions, and if you could put those up now, that would be great. So how would you describe your relationship with cannabis? We're just trying to get a sense of to what degree you have any perspective on this. Maybe tell us if you're not a user and you have no interest, or you're not a user but you're curious. As James, you were saying, there's quite a lot of people that are maybe reactivating an interest or have become more interested in it, either recreationally, medically, or both. So we'll give you a couple of seconds to answer this first question. I guess, Shelley, you have a sense of when we're hitting, probably roughly 600 or so responses. So that's great. So about half are just curious, and only a 7% on recreational use. 23% interested or either users of medicinal or interested in medical use, and 10% with that overlap between medical and recreational use. So that's quite interesting. And then we had two other questions that we wanted to throw out there. And I will say, try to think back to a time before Dr. McKillop maybe went through some of the risks and benefits, and answer this honestly, these questions. So first question about, do you feel it can effectively treat symptoms associated with medical and psychiatric conditions? And also whether or not you feel there are adverse effects or drug-drug interactions with cannabis. Again, from the standpoint, if you have questions, please post them to the Q&A section of the webinar rather than the chat. It's just easier to aggregate them there. So Shelley, could you put up the results for the poll here? So medical cannabis can effectively treat, and there's some disagreement, somewhat disagreement. Most people are sitting on the fence or somewhat agreeing, with 12% strongly agreeing. And then with respect to significant adverse effects, not too dissimilar, with about 50% of people agreeing or somewhat or strongly. One other thing before we get to the questions, either James or Jason, could you just speak to a few of the abbreviations that sometimes get thrown around? So you mentioned CBD, other abbreviations that people are probably familiar with are THC, and then maybe provide some kind of definitions, I guess, around medicinal cannabis versus recreational cannabis.
Sure, I'd be happy to do that. I think most people have heard of THC and CBD, but it's important to note that the cannabis plant has literally hundreds of cannabinoids. And it might be helpful to define what a cannabinoid is. Basically, a cannabinoid is any molecule that acts on the body's internal endogenous cannabinoid system, or the endocannabinoid system. So we have an existing signaling system that these compounds act on, and THC has the most significant psychoactive effects by its impinging on the system. But CBD and many of the other molecules in the cannabis plant also are biologically active in terms of changing the signaling in the brain and outside the brain also.
That's great. Okay, well, let's move to some questions. I think if you want, you can unshare your slides for now. And we'll start in with the topic of chronic pain. As I mentioned earlier, I'm going to try to incorporate questions that were sent earlier, as well as other questions that get sent in. And so we may have a bit of a mix of things. So this was a question talking about a person with chronic back pain, and they've tried CBD oil in the past, but with no relief. And the question is really around, are there different types of cannabinoids that might work better? And I will say that actually there's quite a few different posts or questions that talk a little bit about, is CBD more effective than THC, or something that has a mix, or is there something about the format, like CBD oil versus administration through an edible or some other format? So either Jason or James, how would you respond to this?
So I'm happy to take that. It's a great question. When you say CBD oil, I'm assuming that's an oral ingested drop format as opposed to a topical. So that would be my assumption. We did look at the evidence recently, and there was a link put in the chat to our guideline on the topic about the role of different forms of cannabis and cannabinoids in helping to manage chronic pain. We found 32 randomized controlled trials. All of them looked at oral formulations, 2 topical. None of them looked at inhaled forms of cannabis, which is a limitation, because we know from population studies that a number of individuals well use, whether they vape or whether they smoke, they well intake cannabis through the respiratory system. What we found is reasonable evidence that a minority of patients well experience an important benefit. When I say a minority, I mean versus placebo, you get about 10% more patients that will report an important reduction in their pain severity. So you have to treat 10 patients with a cannabis product for one to report an important benefit. So it won't work for most, it will work for some. What kind of formulations did they look at? Well, again, we had primarily only ingested forms, sprays or drops, and it was almost entirely combination products. So it would have some amount of THC, some amount of CBD. We wanted to look at subgroup effects to see if there were differential properties between very high THC and almost pure CBD products. The clinical trials that have been published thus far did not allow us to do that. So when we presented this information to our panel, which included patient partners who lived with chronic pain, clinicians that deal with chronic pain, they felt that it was reasonable for patients with chronic pain who had not achieved sufficient relief with their usual care outside of cannabis products, that they could be approached to consider a trial of oral cannabis or cannabinoids. We suggested it might be reasonable to start with a product that was higher in CBD, because we know most of the adverse effects associated with cannabis are due to the THC component. And if people don't find relief with that higher CBD and they wish to go a little further, it makes sense to try a combined product, THC and CBD. And if they see a partial response and they want to see if they can augment that a bit further, then they can experiment with a higher level of THC to see if that helps. Now, as James said, there's the possibility of drug interactions. This is something that should be done under monitoring. You should inform your healthcare provider that you would be interested in this. And so it should be done under some form of supervision, aside from your local bud tender, who may offer you a lot of advice. It may not be advice that is considering all the rest of your health issues that are going on. So can it work? It appears as for a minority of individuals, there will be some relief. For a majority, there will not. So as you heard before, it's not an easy answer. Either it works or it doesn't work. It appears to work for a minority of individuals.
So we'll come back to that in a minute. I want to pick up on another subtype of pain that has been a question of interest, which is around neuropathic or nerve pain. And in some of your studies, I think you have done analyses looking at whether or not cannabinoids may be helpful for nerve pain, like sciatica or other forms of diabetic neuropathy.
Yeah, so there's sort of three buckets of pain that we consider if someone has chronic pain. One is the neuropathic, and you gave some great examples of that. The other would be something called nociceptive, which would be osteoarthritis. And the third one would be central sensitization, things like fibromyalgia. We did undertake a subgroup analysis to see if there were differential treatment effects based on the type of chronic pain. We did not find evidence for a difference in effect. So it appeared, at least for now, that if you are going to achieve some benefit, it may not be affected by the type of pain you present with. But I will say that this is a complex issue. When people develop chronic pain, they may start with very specific types. Neuropathic. The longer the pain goes on, the more complicated it becomes. You very often have people that develop mixed types of chronic pain the longer they are dealing with a condition. And so it's very challenging to have completely pure populations. That may have complicated our analysis.
So a couple of other questions that have come up related to pain specifically. This is a person who says, I currently use Tylenol and gabapentin for pain control. How would using cannabis oil affect this? And I guess there's sort of two components to that question. One, is there evidence to add on cannabis oil for treatment of pain or pain control, but also the issue that you alluded to earlier about the potential for drug-drug interactions?
Yeah, so a lot of the drug-drug interactions were seen in the trials of pediatric seizure disorders, the kinds of medications that are used to treat those seizures, when combined with very high levels of cannabidiol, and they used very high levels in those trials, sometimes caused very problematic sedation. Some patients had to drop out of those trials. Certainly, anytime you're introducing something new into your treatment regime, you want to work with your physician to make sure they're aware of that and to explore the possibility of drug interactions. What I will say is that in the trials that we looked at, the 32 randomized trials, they looked at cannabis or cannabinoids versus placebo, but all of these trials largely allowed patients to continue on taking their standard care. So it's very difficult to get ethics approval these days to do a trial where you have patients dealing with chronic pain and they're suffering, and to deny them their usual care. So they really did look at cannabis as an add-on agent in the vast majority of these trials. So it suggests that there may be benefit for a minority of individuals by adding this therapy on. There's been a lot of interest in terms of understanding whether or not making medical cannabis products available for chronic pain might help patients reduce the amount of opioids that they're taking. And the jury is still out on this. We did look at that through observational studies. We don't have good randomized trials on the topic. The observational studies did suggest an effect. But again, until we have good randomized trials, we don't know. And I'll just say also that one of the reasons that cannabis became of interest therapeutically was there were a number of observational studies in the US. In the US, cannabis is illegal at the federal level, but it is legal in a number of individual states. And by looking at the prescription drug monitoring data in a number of states, they saw that when cannabis became legally available, either for recreational or medical purposes or both, they very often saw a decrease in certain types of medications. Not always, but they often saw a decrease in medications typically used to treat pain, anxiety, sleep disorders. And so they began to wonder, might patients be substituting this for their usual prescription medications? And I should say, as with everything in this area, that finding is not replicated across all studies. Some studies have found yes, some no. But again, there does appear to be some evidence to consider the possibility that adding on cannabis to usual care for chronic pain may provide benefits for a minority of patients.
And I'm going to sort of switch categories soon, but there have been a couple of questions about people with multiple myeloma or other kind of cancers and cancer pain. And it should be said that the systematic review and recommendations that you did recently included both cancer and non-cancer pain. Is that correct?
They did. Now we found it wasn't compelling enough. We found some evidence to suggest that cannabis might be less effective for cancer-related pain. It wasn't compelling enough that we made separate recommendations. Now that changed a little bit when we looked at the evidence for cannabis and sleep. We had two major outcomes. One was sleep quality, and we didn't find a lot of evidence of a differential effect between chronic cancer and chronic non-cancer pain. When it came to sleep disruption, we did find what we felt was a credible subgroup effect. And it appeared as if individuals that were living with chronic pain due to cancer did see much less benefit in terms of disrupted sleep when they used medical cannabis products versus those with chronic non-cancer pain. So you're quite right. In our guideline, we didn't have enough evidence that we felt we could, confidently make separate recommendations. There was some suggestion cannabis might be less effective if you're dealing with pain due to chronic pain due to cancer. And hopefully with new studies coming out with more evidence, we'll be able to get a better hold on that.
That's great. Let's talk a little bit about a few neurological conditions. There were a few questions specifically about whether cannabis has been studied in Parkinson's disease and can help with any of the symptoms of Parkinson's disease. And I will also say that there was a separate message about essential tremor, which is another totally separate condition from Parkinson's. So any studies that can inform that at all?
I'll just say in our sleep review, there was one randomized trial that did enroll patients with Parkinson's. And it did suggest that there could be, again, some limited benefits for sleep. I can locate that trial and send it if it's possible to send it to the person that's interested for further information on that. And I don't know more than that. I'm going to pass it over to James.
Well, I think that what that point highlights, Jason, is that there are very few studies on the topic. I think there's a lot of interest because some of the strongest evidence has come for applications to neurological conditions in children and for seizure disorders. And some of these conditions also have similar underlying pathophysiology. Excuse me. So biologically, it's possible, but that alone doesn't make it even probable. And there really is not a lot of evidence at this point. I think that the reality is for adults and older adult neurological conditions, there's just vanishingly little controlled evidence that would be supportive at this point. Now, the other point I'll make is that we hear lots of positive anecdotes from patients, and we don't discount them or disregard them. I think that when we're talking about cannabis medicine, we're talking about a broad class of different products and different compositions, and patients have to do a lot of trial and error. And in some cases, it may be that they come across something that is very beneficial that hasn't been systematically studied yet. The other reality is it may be expectancy or placebo effects, but we do hear very positive reports. And I think that I suspect that you can find some of those reports when it comes to Parkinson's disease, for example, but when it comes to controlled evidence, there's really very little to speak of.
And one of the conditions that may have been a bit better studied is multiple sclerosis. And there was a question sent in about whether or not there was much evidence around the use of cannabinoids for treating spasticity or other elements of multiple sclerosis. Can you speak a bit to that?
Yeah, absolutely. It's in some ways it's the opposite, because that is an area where there is quite a lot of evidence. And in fact, one of the pharmaceutical cannabinoid medications, nabiximols, which is a oromucosal spray that is a combination of THC and CBD, has been approved by Health Canada for treating spasticity in multiple sclerosis. One of the distinctions that we often find helpful is navigating between medical cannabis on the one hand and pharmaceutical cannabinoids. And just to clarify for folks tonight, medical cannabis usually refers to plant products, whether or not they are actually dried flower plant or reformulations of plant products into vape oils or oral oils or topicals, whereas the pharmaceutical cannabinoids are compounds that are manufactured like other pharmaceuticals that mimic the compounds in the plant. And so in some ways, these are different from each other. The pharmaceutical cannabinoids are much more like traditional medicines. They have to be prescribed by a physician. They have a drug identification number. They have precise doses that are associated with the clinical benefits, whereas medical cannabis is much more a fuzzy set of products, pills, oils, edibles, topicals, sprays, vapes, dried flower, and represents a much more kind of heterogeneous set of products people use.
One more question related to our neurologic condition, and then I want to tackle some of the questions that came in around adverse effects, because I think it's important to balance the evidence around therapeutics with what we know about adverse effects as well. Can you comment at all about the use of cannabis in dementia? And there's been a few questions around that topic specifically, but any literature on that? And then there was another question talking about just the effects generally on older adults and adults over the age of 65 who might have some form of frontal brain damage, frontal lobe damage, whether through stroke or fetal alcohol syndrome, just whether there's what's known about that. But let's start with cannabis and dementia first.
Well, at this point, I think that there's a lot of interest. Not a lot of randomized control trials have been undertaken. There's a lot of preclinical data that does suggest that cannabinoids can have neuroprotective effects, but it is much more kind of lore than evidence at this point. And to your broader question about cannabis use in seniors, it's a very tricky area because even in this literature, which is not very extensive in adults in general, there are even fewer studies in seniors, and there may be important differences in terms of metabolism, what are referred to as the pharmacokinetics of cannabis in terms of how quickly it's absorbed, the extent to which it's absorbed, the speed with which it's metabolized and excreted. And so we don't really know a lot about how the aging body processes cannabis differently, or necessarily the extent of the drug interactions. We know about some drug interactions, especially with some of the anti-seizure medications, with warfarin, which is a blood thinner, but there are almost certainly other drug interactions that we're not aware of yet.
Yeah, my understanding is the potential is relatively high when you look at the way that the cannabinoids may inhibit certain enzymes in the liver as well as other transport proteins. So it's one of these things that we should approach with caution, especially related to many psychiatric medications that are also metabolized through those same pathways. But there is a lot less formal actual studies looking at those drug-drug interactions. So it's more theoretical or based on the mechanisms of action.
That's exactly right. And I think that, with regard to psychiatric medications, fluoxetine, a very widely used antidepressant, is known to actually synergistically increase the effect of cannabis. And that's an example of sort of a reverse interaction in the sense that it's not inhibiting, or cannabis isn't doing the inhibiting of its effectiveness. So from my standpoint, I often say there's no free lunch in pharmacology. If a drug is biologically active, you can't expect that it will only treat the condition and not have any other relationship with any other aspects of the biology that's happening, including interacting with other pharmacological agents.
Well, I think it's horrible that you're destroying our wishful thinking and placebo reactions about that. But you're absolutely right. I think there's always a lot of optimism that comes out, and I think it's reflected in many of the questions. When there's little known about a substance, there's a lot of optimism about, this will be a cure-all, or this will treat all these multiple conditions, and it'll do it without adverse effects. So speaking of adverse effects, here's a question. Everything I've read about cannabis warns about the problems of daily and longer term use. How does this apply to seniors who might be using medical cannabis for chronic pain over a longer period of time?
So I can weigh in on that a bit. So we did two things for our work in this space. So we looked at the adverse events that were reported in randomized trials, and these trials only follow individuals for no more than 6 months. So we don't have particularly long-term data. What we did learn from that is that there are a number of transient, somewhat modest adverse events, a little bit of impaired attention, a little bit of sedation, in some cases, some dizziness. And they did affect a greater proportion of those individuals that were prescribed cannabis over placebo, but it was not a large additional differences. What we call the risk difference, or the increased proportion of patients that were prescribed cannabis over placebo that experienced one of these transient modest effects, usually ranged between 2 and 5%. So again, we saw modest evidence for small benefits, and we saw modest evidence for small harms. And this is why we landed on a conditional recommendation in favor, but to approach patients and see if they were willing to accept the possibility of a small risk of transient harms for the possibility of, small risk of benefits. We had to look to the observational literature to get our information on long-term harms. And we did undertake that review as well. If people go to the chat box and they click on the link to the guideline, you will see all of the linked evidence syntheses that we did. So we did find some evidence in terms of the increased risk of motor vehicle accidents, falls leading to fracture, things such as, suicidality. But all of the evidence was very low certainty. We had very limited information on this. There's much better evidence if you look at recreational use of cannabis, but this tends to be quite different than therapeutic users. So we were a little bit nervous to extrapolate the risks associated with long-term high THC recreational use to people that were using for therapeutic purposes. So it's an area of a lot of uncertainty in terms of long-term harms. And unfortunately, as you're going to hear as a running theme throughout this talk, we need more evidence to give more confident answers. But in terms of short-term adverse events, that we seem to have a better handle on, typically mild transient harms, again, not affecting large proportions, but an important minority.
There was a question that came in around, can you address this issue of potential memory loss as a side effect of using cannabis regularly as a sleep aid? And I'm wondering, in your review associated with cannabinoids for sleep, did you come across any consistent adverse effects or memory loss as a side effect there?
So with our review on sleep, we looked at only randomized controlled trials. And again, the problem with these randomized trials is they don't follow patients long-term. We found nothing where people follow patients longer than 6 months. So again, did we see some evidence of some transient memory impairment? Yes, we did. It affected a minority of individuals. I can't say anything about sort of long-term use and what happens after, more than 6 months of using cannabis to address sleep.
While we're on the subject of sleep, other questions have come in about, was there anything that emerged in terms of particular strains or, THC, CBD combination?
Yeah, so almost every there was only one trial that administered an inhaled form of cannabis. Every other trial basically used the oral mucosal sprays, the synthetics that were combinations of CBD and THC, or in some cases, just synthetic THC. We did not find a single trial that only administered CBD. So it appeared as if the people setting up the trials felt quite convinced that there would have to be some amount of THC if you were going to try to optimize sleep in people that were having difficulty in that space.
James, at the beginning of the talk, you mentioned one of the aspects of the research program was looking at cannabis hyperemesis syndrome. And actually, I will say clinically, we have seen quite a bit more of that since, I would say, the last few years in the Emerge and on the ward. So one of the questions that came in is whether or not you've done or what kind of research is being done in this area. And, if maybe even just provide a brief definition of it as well for people.
Sure, I'd be happy to. So to start with the definition, cannabis hyperemesis syndrome is a condition that is characterized by intense stomach and GI pain, nausea, frequent vomiting, and a great deal of discomfort, kind of whole body discomfort associated with either feeling too hot or too cold. It's an unusual syndrome for a couple of reasons. It is relieved by taking very hot baths or showers, and it's not clear why that's the case, but it's very common for patients to use very hot baths or showers to relieve these symptoms. And it also does not respond to most of the traditional antiemetic medications. As you alluded to, Anthony, it has become much more common recently. It used to be a bit of a medical unicorn that very occasionally it would be described and was sort of an unusual manifestation of extremely heavy cannabis use. But the reality is that THC has been creeping up in cannabis products for quite some time. And this started in the contraband market with ever increasing levels of THC in illegal cannabis. But in the legal cannabis market and in medical cannabis products, the levels of THC are much higher than they would have been historically in the marketplace, often at 15, 20% or higher. And it's believed that as a result, we're now seeing much higher rates of CHS, or cannabis hyperemesis syndrome. We've only started doing work on this topic recently. We were asked to conduct a review by the Society for Academic Emergency Medicine because emergency physicians are seeing this much more commonly, and they're trying to develop guidelines for how to manage this in the emergency department, because obviously their go-to strategies of anti-nausea medications are not working. So we reviewed some of the other compounds that have been used with a little bit of success. These include a capsaicin topical cream that seems to provide some relief applied to the abdomen. Again, there's some sort of peculiar pathophysiology probably implicating the hypothalamus and changes by virtue of persistent exposure to THC that's leading to the relief by hot showers, hot baths, and capsaicin. Also, they're finding that we found in our review that antidopaminergic agents seem to be effective. But the long story short is, it seems like qualitatively different medications are going to be needed for a condition that is much more common. And just to sort of go back to something that Jason referred to before, a lot of the side effects in medical cannabis are largely attributable to THC. So to the extent to which people can minimize their consumption of THC, they're going to also be minimizing these cognitive effects, phenomena like dizziness, the possibility of developing physiological dependence and a withdrawal syndrome when they stop using cannabis. And the only long-term outcome to resolve cannabis hyperemesis syndrome at this point is discontinuation of cannabis use. Ultimately, termination of use is associated with the termination of the syndrome. And so it seems to be very much THC dependent.
That's great. I'm conscious of the time, and in the next 7 minutes, we only have 88 questions to get through, so we'll do our best. Is there any evidence that it can help anxiety, and maybe speak more broadly to indications or evidence around psychiatric disorders? And I think you did allude to this nicely at the beginning, James. There's maybe more evidence about potential adverse effects and much less evidence to support a therapeutic value, but maybe just summarize that literature again.
I'd be happy to. And my background is as a clinical psychologist. I'm a registered psychologist. And I think that what we see from a lot of observational studies is that people will report using cannabis to relieve their anxiety and do experience, by their reports, some benefit. What we don't know is whether or not there's evidence from randomized controlled trials, which are essential for actually controlling for the expectancies around cannabis, and whether or not that relief is simply because they believe that it's going to be anxiolytic or soothing. But the other issue that I am actually very concerned about is that cannabis is not the only drug that people will self-report finding is helpful for reducing anxiety. Alcohol is widely described as reducing anxiety, but we would never prescribe medical alcohol for social anxiety disorder, because the reality is it only addresses a short-term symptom and ultimately tends to require progressively greater amounts in order to maintain that relief, leading to a substance use disorder. And clinically, it also fosters a fair amount of avoidance of the things that are producing anxiety. And the path to recovery typically is engaging with the world, not avoiding the world. So one of my concerns is that the observational findings may be pointing us in the wrong direction, to the extent that people report benefit, but whether or not that's the case relative to placebo, or whether or not that's benefit that is going to be long-standing and not a risk factor for developing cannabis use disorder, is not clear at all. So I have a lot of concerns, and as more trials are emerging, the evidence is not convincing. So I'm concerned that there may be real harm there.
And I think there was another post here about whether there was any research being done looking at cannabis for PTSD. And I think this is another area where there's really a lack of evidence, but a lot of people using. So there's quite a bit of anecdote. And I think Jason and James, some of your work with Veterans Affairs Canada also is sort of probing that issue, isn't it?
Yeah. So, sorry.
Go ahead.
Oh, so yeah, I mean, there was just a report released by Veterans Affairs Canada this last year. They reimbursed a little over $120 million for medical cannabis to veterans in Canada. So that's more than their reimbursements for all prescription medications combined. They've estimated, based on current patterns of growth, that by 2025, they will be reimbursing over $300 million for medical cannabis per year. And you're quite right that a lot of that is being used in individuals that have PTSD. We've been looking at some work with one of the researchers at Veterans Affairs Canada that's been looking through their administrative reimbursement data. And as you might imagine, it's a complex population. They very often have chronic pain in combination with PTSD. And we know even less about the effectiveness of cannabis in patients that have these comorbid conditions. They tend not to be selected for clinical trials of chronic pain. So it's an open question. It's widely being used, and it's an area of urgent research. Really, all I'm aware of is sort of one small pilot study that was done that found limited evidence that use of cannabis seemed to help a little bit in terms of nightmares during, associated with PTSD. That was it. But it's an area of great interest that needs some more study for sure.
So we're actually kind of at the witching hour, and I do want to thank everybody for all of the contributions today. I want to thank Jason and James, and I did just want to highlight again some of the resources. James, do you want to just speak to what people can find on your website in terms of the research that's being done and the newsletter?
Absolutely. Thank you, Anthony. So for people who are interested, I would very much encourage you to avail yourselves of our resources. We send out a monthly newsletter that highlights some of the work that faculty are doing and knowledge translation products, and tells people about upcoming public events. We also have on our website a whole library of research summaries and evidence syntheses. So we've done reviews on, is CBD safe? What are the effects on lung harms? What about use in pregnant or lactating women? If you've got questions, I hope that our website has answers. If it doesn't, reach out to us, because we often do respond to solicitations to pursue areas, because really, unfortunately, if you just Google cannabis and anything, you'll get a lot of hits, but you won't get a lot of evidence. And we're really trying to put out much more credible information.
And I know you alluded to the Science of Cannabis course as well, but just another prompt for that, and maybe the link could be added to the chat as well. Anything else that you wanted to say about the certificate course?
Yeah, for people who are really interested in this, these are 3 university courses, all offered online by McMaster faculty who are affiliated with the DeGroote Centre, but also a number of other research centers. The first course is just on everything you want to know about cannabis fundamentals. The second course is all about what's known about risks and harms from cannabis. And the third course is about how we appraise evidence in terms of its quality and what we know about the evidence for cannabis for medical application. So if you're particularly interested, this is a way to actually get a formal certificate of professional learning, all on the topic of cannabis.
Fantastic. I did just want to highlight as well, if you're not a subscriber yet to the McMaster Optimal Aging portal, the subscribe button is on every page and in the header of the website. And that would, like thousands of Canadians, you would get a weekly email newsletter that would promote our upcoming webinars like this in the series, as well as our enhanced content like e-learning, video posts, evidence-based blog posts on health and social topics, as well as evidence summaries. So I encourage you all to subscribe. We also have videos with McMaster experts, including a really great one with Jason earlier on, where we talked a bit about the challenges around evidence and cannabis, and our series on diabetes and hypertension as well. And then we have a selection of interactive e-learning lessons, including ones on walking speed and how best to manage osteoarthritis symptoms through exercise, social isolation, and other topics, including one upcoming related to anxiety and another on chronic pain. If you are on social media, you can subscribe to the portal's YouTube channel, as well as Twitter and Facebook for evidence updates. So can't thank you guys enough. I think there is really no question that we could spend another hour going through the volume of excellent questions. So on behalf of the Alumni Association, I would love to thank both Jason and James for joining us, and for everybody here tonight and your participation. I thought it was very informative. So we'll stay tuned, and I think there's a little hold the date for our upcoming webinar in January as well. Thank you all very much for joining us.